Gastroesophageal reflux disease is my favorite disease to deal with. It is not always clear what's going on. It requires a lot of testing to get figured out and is a very satisfying operation anatomically, but more importantly, it takes people many times who've been miserable for decades and returns them back to a state of health where they feel like their intestinal tract is working like it did when they were a teenager. And they're very grateful, and that feels good as a surgeon. So understanding what's going on with gastroesophageal reflux disease is important, and you need an experienced surgeon to guide you through that. Frequently, the gastroenterologist will make sure that they understand that what your risks are in terms of cancer with gastroesophageal reflux disease. But getting you to the point of needing knowing that an operation will help you is a critical pathway, because not everybody can be helped with this disease, and you want to interact with this disease before you transition to being too far gone with it to get an operation. Gastroesophageal reflux disease is associated with a lot of terms that we need to clarify, because the terms that laymen use and the doctors use are not the same, and frequently acid reflux really isn't acid reflux, but it is reflux. So let's talk about the underlying anatomy and some of what goes on and how the terms all tie in with it, and then we'll be able to go on from there on how we can deal with it from a surgical standpoint. The esophagus is a tube that goes from the mouth down into the belly cavity where it joins the stomach. It has to go through the chest to do so, and when it gets at the lower end of the chest, there's a boundary between the chest and the belly that is the diaphragm muscle. And this is normal anatomy. The esophagus should go through the diaphragm. There should be a section of esophagus in the belly as it joins into the stomach. The diaphragm should be relatively tight around that. That's called a hiatus. And at the junction of the stomach and the esophagus, there's a round muscle. And that round muscle stays closed most of the time. But when you eat, it opens and lets the food come through, slams shut, and then stays shut. If you overeat, that muscle gets stretched out. And if you overeat a bunch, you'll stretch that out permanently, or if you vomit a lot. But this is why acid reflux disease is a disease commonly of affluent countries. That stomach slowly stretches that muscle out so that acid can come up the esophagus and start burning the esophagus. Frequently, people experience that as a burning sensation below the sternum. Sometimes they feel it up in their throat or in their mouth. And that's what we like to call heartburn. Some people call that indigestion, which is not quite the right medical term. Indigestion means you've got problems down lower with your diarrhea and stuff. But heartburn and regurgitation are symptoms that are associated with the acid going the wrong way. People with gastroesophageal reflux disease, or GERD, don't make too much acid. They just have acid in the wrong place. Acid is a normal part of digestion. It's supposed to be in your stomach, and it helps you digest food, but more importantly, it sterilizes the food. If you lived in Bangladesh and you were drinking pond water and you weren't eating food that was prepared well, or even discarded food particles, you need that acid to protect you from the diarrheal diseases that kill so much of the world's children. So acid is a part of sterilizing your food source, keeping you healthy. And acid is normal. But acid is supposed to stay here. You're supposed to get a little bit once in a while up this direction. But for the most part, the acid comes this way, and your body gets rid of it almost immediately by sterilizing it and neutralizing it with pancreatic juice that neutralizes the acid. So the acid is really partly only in the stomach. If acid is coming up, it is usually because this muscle has become weakened. That's called the lower esophageal sphincter. Now, frequently people will say that they have a hiatal hernia, meaning they have acid reflux. And a hiatal hernia frequently is associated with acid reflux, but a hiatal hernia is an anatomical problem that is somewhat separate, but right there. A hiatal hernia means that your stomach has gone through an enlarged opening, a hiatus, around the esophagus, and the stomach is now up in the chest a little bit. And your esophageal hiatus is supposed to be just a slit that the esophagus comes through. But if you get pregnant and you experience a 9-month pregnancy, that all stretches open and that hiatal hernia gets way bigger and frequently stays bigger. And that is a hiatal hernia. So having a hiatal hernia really worldwide is a normal part of the human experience. And normally it doesn't result in acid reflux, although a lot of women during pregnancy will experience heartburn like they've never had it before because of that ongoing back pressure up against the diaphragm and the spreading apart of the hiatal hernia. Men, on the other hand, they get a pot belly, and that pot belly lasts for decades. And that also puts pressure on the diaphragm, stretching this gap open and resulting in the hiatal hernia. So surgically, to fix the anatomy, to get a hiatal hernia fixed, and to fix the lower esophageal sphincter, to get you back to normal anatomy again, it's a two-phase operation. First is to pull the stomach down and fix the wideness of the diaphragm to get the hiatus to the normal size, and then put a series of stitches in this junction here to bring the stomach back and get that stretched out muscle back to normal position. And that's what I do when I do a Hill repair. The symptoms of gastroesophageal reflux disease are not going to be the same from patient to patient. Most patients will experience heartburn, burning substernally. They'll experience regurgitation of food particles or an acid taste up into their mouth, and that's really the classic symptoms for esophageal reflux disease. Some, on the other hand, will have a burning sensation lower in their stomach area, below their ribs. Others will experience it mostly in their throat, and there's a subset that have what's called laryngopharyngeal reflux that have a predominance of symptoms in the throat, with a chronic sore throat, or a raspy voice, or laryngitis that recurs without any infections, or a chronic cough, or asthma, or a sensation that something is just stuck in their throat when there's nothing stuck in their throat. They just feel like it's there, and they clear their throat all the time trying to get this out, but it really isn't there. In patients with laryngopharyngeal reflux, as a predominant manifestation of their acid reflux, really need to also have their ear, nose, and throat evaluation to make sure there's no other concomitant diseases there. But frequently, they're the most satisfied to get rid of those ongoing symptoms, particularly if it's partly asthma and chronic cough and they can't talk if they're a school teacher and things like that. So there are some benefits many times that people don't realize once they've had their heartburn removed, that a lot of their throat symptoms also go away. The complications of gastroesophageal reflux disease can be many. They can be long-term slow actions, or they can be a sudden problem. For most people, they have heartburn, they realize it, but they don't realize what that reflux is doing to their esophagus. Gastroesophageal reflux disease by itself is a precancerous condition. It results in cancer of the esophagus, right here where the acid is most concentrated. And some people will develop cancer of the esophagus as young as age 30, but it's most common in men. White, middle-aged men are at greatest risk of developing cancer of the esophagus over any other population group for some reason. So if you've had ongoing acid reflux, you need to have your esophagus scoped by a gastroenterologist, and they need to look down the esophagus and make sure that the lining of the esophagus here is not precancerous. That's a condition called Barrett's esophagus. Barrett's esophagus means that there's been enough destruction there already that a mutation has occurred and the lining of the esophagus has transitioned from a normal lining to a precancerous lining. And that condition with Barrett's esophagus requires ongoing surveillance by the gastroenterologist, because 1% to 0.5% of those patients per year will go on to develop cancer of the esophagus. And that is generally going to be in the male population, and females have a little bit lower risk of that, or substantially lower risk of that, but they still need to be watched. Acid reflux disease can also result in a scarring phenomena inside of the esophagus called a stricture that makes it more and more difficult to swallow. And even in the absence of a stricture, acid reflux disease burns out your esophagus. It's trying all the time to clear that acid out of there, and it slowly burns itself out. And the esophagus becomes weaker and weaker and weaker. It's a condition called an ineffective esophagus. It's directly related to acid reflux disease. And there are certain people that will get so that they can't swallow, and we can't do an operation because their esophagus is too weak for an operation. You want to intervene with GERD before things deteriorate to that point. People can die from acid reflux disease. If that acid comes directly up your esophagus and burns your vocal cords at night, in the middle of the night, it may cause a laryngeal spasm where you cannot take a breath in, and you'll die. That's rare, but it does occur. So acid reflux disease can kill people from cancer. It can kill people from laryngeal spasm. And more importantly, there are patients with underlying lung disease where that reflux, as it occurs up here, will spill over into their lungs and result in a condition called pulmonary fibrosis. In pulmonary fibrosis, once it begins, is a one-way destruction of the lung and premature death. In the world of lung transplants, frequently they will not do a lung transplant on somebody with pulmonary fibrosis until they've had an anti-reflux operation, so that the transplanted lung doesn't get destroyed by the same reflux problem. So it's possible for reflux disease to affect more than this area and affect the more important organs upstream. Most patients with acid reflux disease are treated with acid-reducing medications because it makes them feel better. It is effective in palliating the problem. It does not solve the problem of a weak lower esophageal sphincter. It doesn't fix a hiatal hernia, but it blocks the acid secretion so that what refluxes is more of a neutral pH, and therefore you don't feel it, you don't feel it, you don't worry about it, you go about your day and you keep eating the same stuff. You generally, frequently keep on with the same habits that got you into the acid reflux world in the first place. Proton pump inhibitors are the most effective medication for that. That would be your Nexium and Prilosec, the purple pills, Protonics. There are a number of them on the market now. And if you read the package label says you can use this stuff for 6 weeks, 3 months max, but you should stop it. That's what the FDA has approved. They are, however, commonly used for decades of continuous use in patients. And consequently, there are now emerging evidence that these proton pump inhibitors can cause a number of significant problems. And I'm going to use my mother as an example here. My mom was on proton pump inhibitors for 35 years, and she now has kidney failure. Kidney failure is 4 times the risk in patients with these medications. She's had a heart attack. You have 4 times the risk of a heart attack. She's developing dementia, and patients with these medications for decades have a higher risk for dementia at 4 times the higher risk. They also have a higher risk of osteoporosis. What she hasn't had is the infectious complications, which are infectious diarrhea complications, because the stomach acid is no longer there protecting you from the outside world. In patients who, say, are world travelers and want to go to Africa, India, Mexico even, if they're on their proton pump inhibitors, have an increased risk of infectious diarrheas. It can be pretty significant, particularly if it's in the C. difficile world. So long-term use of proton pump inhibitors is increasingly being brought into the discussion in patients who have acid reflux disease. The other way to deal with acid reflux disease is to fix the broken anatomy, and that's where surgical options come in. When an operation is done for acid reflux disease, it is frequently done in the hospital. Some patients are healthy enough that they can have it done in an outpatient setting. It's frequently referred to by laymen as a hiatal hernia repair because that's part of the operation. And historically, back before they knew the lower esophageal sphincter existed, the thought was, all we got to do is fix that hiatal hernia. And if all we do is get in there and bring the stomach down and close the gap here so that that stomach's in the right place, 50% of people will have their reflux solved, but 50% will not. Consequently, hiatal hernia repairs right from the get-go had a very bad reputation back in the days when you had to be opened all the way up to get this big operation for a 50% improvement rate. That wasn't good. So in the 60s, they started doing operations to improve the function of the lower esophageal sphincter and fix this problem at the same time. And then the results became more like 90 to 95%. The operation in America that is most commonly done is called a Nissen Fundoplication. And that's a big word, but the fundus is this part of the stomach here. A fundoplication means that it's a plastic surgery with the fundus of the stomach. And with that operation, this part of the stomach is wrapped around the esophagus after the hiatal hernia is repaired to prevent the acid from coming up. And three-dimensionally, I can't draw it. But if this is the stomach, and the stomach, or this is the esophagus, and the stomach is a big bag down below that, you take the stomach and wrap it around the esophagus permanently and sew it in position there. And that acts like a bit of a fist. And as your stomach fills up more, it gets tighter and prevents acid reflux. It's a permanent distortion of the stomach, and it's a permanently ignoring the lower esophageal sphincter. And it prevents acid reflux and is a very effective long-term cure for acid reflux. But in the process of having the stomach wrapped around the esophagus like that, you lose a couple of normal functions, one of which is burping. The lower esophageal sphincter is under your brain's control. If you fill up with dinner at Thanksgiving, that muscle, your brain tells it to relax, and you can tell your stomach to relax that muscle and make yourself burp too. There are burping contests because of that. But that muscle, that sphincter muscle, can relax and let the pressure out of your stomach. If you have a Nissen Fundoplication and you drink a can of root beer or champagne or a can of beer, all that effervescing gas, you will not be able to volitionally burp out. And consequently, your stomach bloats, you fart more gas out the lower end, and that's a condition called gas bloat that affects about 10% of patients with a Nissen Fundoplication. And for some people, that can be very distressing because their contour changes when they're so bloated up. The other problem with the Nissen Fundoplication is that you can no longer vomit. When you vomit, you put a lot of abdominal pressure down low here, and this muscle opens up, and you expel what's in your stomach. Now, nobody likes vomiting, but when they vomit, they don't want it to be a lot of work, and they do want it to be effective. And if you get the flu and start vomiting, with a Nissen Fundoplication, you end up retching and retching and retching, and you can't get rid of the food poison that's in your stomach. It has to go all the way through you, and it can be a very distressing situation. So you lose a couple of normal functions with a Nissen Fundoplication. Another option is a LINX device, which is a magnetic ring that's placed right across here. The hiatal hernia is repaired, the ring goes around there, and then you have a foreign material that's around your esophagus all the time. It's been around now for about a decade. We know generally what's going to happen. Its results are about 20% lower than that of a fundoplication or a heel repair in the long run, and there's a predictable rate at which these things need to be removed, partly because they erode into the esophagus, partly because they cause difficulty swallowing as they get scarred up around there. So the long-term results on the LINX, I think, are still out. The short-term results are acceptable and they're good, but I think that the LINX device really should be used for patients who have conditions where they really need to vomit and they have acid reflux disease. People who have, say, migraine headaches, who are vomiting 4 times a month or violently vomiting on a regular basis. Patients who have Meniere's disease where their inner ears are spinning and they've also got acid reflux disease. Something like the LINX disease, a LINX device allows them to vomit, allows the reflux to be diminished, and can be a solution for them. But I think that's a relatively small group of patients. Now, the operation that I do is called a Hill repair, and the Hill repair is kind of a natural approach. And that is, although it takes surgery, with the Hill repair, at the end of the operation, we have normal anatomy, where the esophagus has a stretch in the belly cavity, the hiatal hernia has been repaired, and the lower esophageal sphincter repair has been accomplished so that your brain still controls this whole area. And as a result, you end up with normal function, normal burping, normal ability to vomit, and elimination of the ongoing acid reflux symptoms. So the Hill repair is done laparoscopically, usually as an outpatient surgery. The operation lasts about an hour and a half, a surgeon, an assistant, and a general anesthesia. If you're young and healthy, it can be done in an outpatient setting at Meridian Surgery Center. For older patients, it's frequently in the hospital. With this operation, we make 5 incisions in the upper abdomen. It allows us to put a TV camera inside. And first part is dissecting this area and bringing the stomach down into the belly cavity. Then a series of stitches are put across here to prevent the stomach from coming back up there. When those stitches are in place, the hiatal hernia is repaired. And then the second part of the operation is putting a series of stitches around the lower esophageal sphincter to bring it back down into the normal configuration. So if your normal is a fist for your sphincter muscle, opening and closing, it's been stretched out with overeating and vomiting through the years. With a Hill repair, we put a stitch in the front and in the back in a series of locations and tighten it down, tighten it down, tighten it down, and bring it back to normal configuration again so that it functions like a fist. And it's under your brain's control. To prevent it from being too tight, we put what's called a bougie inside of there to keep it from being too tight while we're tightening it up. And in the end, the anatomy has been restored, the normal function has been restored, and with the Hill repair, most people can get on with their lives and be eliminated with the acid reflux and not be bothered so much with the gas, bloat, and diarrhea problems that are frequently accompany the Nissen Fundoplication operation. All operations, though, have risks, and with anti-reflux surgery, those risks are inherent and luckily infrequent. Patients with acid reflux disease are expected to have a difficulty swallowing for a period of time after surgery, because when we tighten everything up and do this dissection around here, there's an area about 5 inches long that is all swollen. If you had your ankle operated on and it was swelling up, you'd have trouble walking. And in this situation, you have trouble swallowing. So after the operation, we expect people to be on a liquid diet for a week to 3 weeks. Some of the tests that we do before the operation help define how long we expect you to have that kind of an impairment. But what we don't want is for you to swallow something and get it stuck here where it's all swollen up and start retching, because vomiting destroys these operations. Lifelong, you want to not be vomiting, even though you can, because it automatically is putting a lot of pressure right here where your operation was. The overall failure rate for anti-reflux operations is about 10%. And a lot of that happens in the first 4 or 5 years because of vomiting. So I don't offer an anti-reflux operation other than a LINX device to people who have vomiting conditions otherwise going on in their lives. And you want to have a long-term goal of not doing any vomiting. But up front, the diet is a liquid diet for a week to 2 weeks, sometimes 3. Then soft foods like scrambled eggs, macaroni and cheese, really soft stuff that you don't normally chew too much. And it's usually 2 months before you're eating what we call phase 4 diet. The phase 4 diet is stuff that you normally have to chew a lot. A carrot, an apple, a salad, a hamburger. Those kind of things really do take a while before they're coming through this surgical area without getting hung up. And if you're a gulper, you're going to find out real early that gulping doesn't work with this operation. People need to learn to slow down, chew their food, enjoy their food, and swallow intentionally, particularly as they're going for the first 2 months. After that, most people can get back to all their old bad habits again and things work okay. Occasionally there are people that I'll run into down at the fairgrounds or something. They'll say, hey, you fixed my hiatal hernia 8 years ago, and I love it. It's great. I don't have that stuff. I'm sleeping flat at night. But why is it that I can't drink apple juice? I can drink beer. I can drink wine. I can eat a steak, but I can't drink apple juice. And you can replace anything with apple juice. There's just something weird about sometimes how this works with people, where there are certain things that they just can't seem to swallow well. They learn to adjust and get around it. It's not common, but it is one of those weird side effects that goes along with surgery sometimes. The life-threatening complication that can occur would be to get a hole in the stomach or the esophagus during the operation or shortly thereafter. And vomiting is one of those things that can break a hole down. And what leaks out is spit. It's mixed with acid, and that burns you inside and causes a tremendous infection. So anybody after a hiatal hernia repair is experiencing shortness of breath, fevers over 101, or increasing pain in the first 24 to 48 hours after surgery, we need to do a test where we have them swallow some white chalky stuff and find out if there's a leak going on in there, because that requires an emergency operation to fix. And this has happened to 5 of my patients in 25 years. 2 of them had huge hiatal hernias. 2 of them didn't particularly have anything out of normal for a hiatal hernia repair. None of them died. One of them tried to sue me. They all had big hospital bills, and they all were in the intensive care unit and all were on a ventilator for a few days. One of those guys, one of those patients, had a really kind of a perfect operation. He did well. He'd had 30 years of heartburn. And when he went on from phase 1 to phase 2, a week after surgery, he went home and he ate scrambled eggs. And it went down good. Then he had scrambled eggs with Tabasco sauce, which he hadn't been able to do without punishing himself for years. And then he had thirds with Tabasco sauce. And then he had a little more with Tabasco sauce. Then he got bloated and he began vomiting. And he ripped up his operation, and he ended up in the intensive care unit that night with a reoperation to deal with the hole there. So you've heard that story. You're not going to be that guy, but take it easy with food and activities after surgery, and you'll minimize potential. There is potential for bleeding with this operation. There's a big blood vessel right behind the stomach here that can get injured. That's happened to one of my patients, requiring opening up and stopping the bleeding and a blood transfusion. All operations have some potential for infection. That's also a relatively small problem, since the biggest incision is usually this big. But I've had 2 patients in the last 25 years who've had internal infections requiring antibiotics and reoperation for infections. One of them picked up the MRSA germ in the hospital and ended up with a MRSA germ up behind the heart. So it can be a big deal, and infections you always want to have off on the do not do list with any operations. But fortunately, with anti-reflux surgery, we're not cutting into the guts, we're operating around the esophagus. The leak rate's real low, and the infection rate is also real low. After the operation, there are some limitations. First is the diet. The second is the fact that this hiatal hernia area has been operated on, and that area needs to heal. So we have a 15-pound lifting restriction that goes on for 6 weeks after the operation. So that can become a big deal for people who are doing heavy physical labor. They'll just not be able to do that for that 6 weeks. After that, should be able to work back into normal activities. When you go home the night of surgery, you should be up and around the house, up and around the yard the next day within a week after a hiatal hernia repair. Stair climber, exercise bike, treadmill, walking a track, walking a little dog, all that'll be fine. But if you're walking a German Shepherd and it's pulling on you all the time, that's too much strain on the chest. But you should be able to remain physically active and give your lungs some exercise, but you might feel it a little bit with the hiatal hernia repair. The pain from the hiatal hernia operation, we do 5 incisions in the belly, but the operation, all of this is actually done behind the heart between the shoulder blades, so frequently the pain and discomfort are felt up in the shoulder blade area rather than down low, and frequently that's what bothers them when they are exercising. If that's the case, it's probably best to back off some. So for the most part, the operation goes smoothly, is associated with some unintentional weight loss because you're on a liquid diet and a restricted diet. You can't eat what you want when you want. Hopefully eating nutritious foods, and we'll go over the diet separately. Most people notice an immediate response to their acid reflux symptoms, their heartburn and regurgitation going away. People will frequently notice a little bit of air trapping and feel that is burping initially and be afraid that their operation is not working, but that's really air trapping here rather than burping coming from the stomach. Patients who have a predominance of voice box symptoms up here may not find that their operation gets better immediately. If the real problem has to do with the vocal cords and a lot of vocal cord weakness and hoarseness, the vocal cords are going to take 6 months to heal. I've had patients that are professional singers that want their voice back immediately. It's going to take time for that to happen. The sensation of fullness in the throat will get confused with the difficulty swallowing down below, and that will take a number of months to go away also. Chronic cough frequently also takes a number of months to go away. Asthma will improve in 60% of patients with acid reflux and asthma, but also it many times takes a number of months to go away. So some of the benefits aren't immediately noticed as much as what you're going to notice with heartburn and regurgitation. For most patients with this operation, they're immediately off of their proton pump inhibitors, and lifelong, if they're having reflux, it'll typically be like it is for normal people. Once in a while, they ate the wrong thing, they had too much wine late at night or something, they take a Tums, they take one pill, it goes away, and they're on their way. So just having a little bit of heartburn once in a while doesn't mean that the operation's failed. It means you're kind of back to what normal people experience. Okay, now I've got a really unpopular subject, and that is complications after surgery. All surgeries have potential complications. Some surgeries have different complications from others, but there are some that need to be watched out with every operation. One of those are things that people naturally are afraid of, and that's bleeding. For most operations, the risk of bleeding is relatively low, amounts to bruising, and rarely results in transfusion. If you have religious objections to blood products, be sure and let your surgeon know about that. But rarely do we need to proceed on with any bleeding, transfusion sort of issues in general surgery and the stuff that I'm generally doing. But there are a few things that can increase your risk of bleeding that you need to be aware of. Aspirin increases bleeding, it increases bruising substantially, and unless your doctor feels like you need to be on aspirin despite the fact that you're having surgery, most patients will be taken off of aspirin. Likewise, ibuprofen, Aleve, any of the non-steroidal anti-inflammatories also have the same effect on clotting. So we'll generally have people off of those medications for a few days before surgery. External bleeding is very obvious. If you've got a spot of blood this big on your dressing, it's probably going to stop on its own. If your dressing, however, is soaked and looks like it's continuing, you need to notify your surgeon right away. Frequently, that will get better just by applying pressure. But if it doesn't, it will need to be addressed during a close time frame there. Don't be polite to your surgeon. I like that if you are, but don't wait till morning if you've been bleeding all night. That can be a real problem. And let the surgeon know if you're soaking your dressings. The other way that you know you have bleeding is something you might not think of up front. For most operations, we want you up and around the house the night of surgery. And walking is good. It prevents blood clots. It keeps you mobile. But it also gives us an early warning sign. If you're attempting to walk the night of surgery and you're pale and you're passing out, that's either a heart problem or that's internal bleeding. That's an automatic trip to the emergency room, and nobody should talk you into going to bed because you're dehydrated, you just need to rest. If you're pale and passing out, or just passing out period, when you try and walk, that's internal bleeding and needs to be evaluated that night. Call 911, call me on the way. Infections are also a risk with surgery, and anytime the intestines are cut across, there's a higher risk of infection. Wound infections are not common at Meridian Surgery Center. The risk is about 1%. If your wound is red and angry, if it's draining pussy stuff, if you're having a fever over 101, those infections symptoms are generally going to occur in the first week to 3 weeks after surgery. It's a nuisance. It might scare you, but it's probably not an emergency that requires an emergency room visit. And if you go to the emergency room, you're going to be there 10 hours. Calling the surgeon, texting a picture is the better way to do it, way faster, way cheaper, and will save you a lot of trouble. I had a patient 2 years ago who was pacing in the emergency room with this problem. He'd been there 4.5 hours. He was getting really mad. Other people were going ahead of him. He wasn't getting any attention. And he just went, I'm supposed to be calling Dr. Wright. What am I doing here? And we had it all figured out for him within 15 minutes. So be aware, the emergency room isn't generally the place for that kind of a problem. Let's get it taken care of. Anesthesia-wise, your operation generally involves anesthesia. Local anesthetic has very minimal risks, but if you're allergic to lidocaine or bupivacaine in the dental office, we need to know that because that's what we're generally using, something related to that. General anesthetic and sedation procedures have risk of anesthesia as well. We're generally evaluating that in the clinic as we go along with the surgery evaluation, and patients with high risk are generally done in the hospital setting. Patients with intermediate risks and low risks are in this outpatient setting. But that's part of why we're doing blood tests and EKGs in evaluation before surgery. And sometimes you'll be set up for an outpatient surgery, and those tests will either cancel the surgery and require a cardiac evaluation, or change the setting of the surgery, or tell us something else needs to be done before the operation is done. But we deal with, in the outpatient setting, minimizing the anesthetic risk and getting you through the operation as smooth as possible. You'll be speaking with the anesthesia provider specifically about your situation the day of surgery before you go in for surgery. If you have sleep apnea at baseline, we do ask you to bring in your CPAP mask because that can be helpful in the recovery phase when you're not breathing so well and when you're not as awake, sort of like it helps you at night. Medications that we give after surgery can have reactions too, particularly if you've never seen them before. If you've had problems with certain pain pills before, we need to know that up front so that we don't get you into the same trouble that you had before. But generally, narcotic pain medications are constipating. And the number one distress call I get is usually 4 days after surgery. Somebody hasn't thought about how their bowels are working. They've had their surgery, they're doing okay, but now they can't poop. And it can be the most miserable part of your operation if you're bloated after an abdominal surgery and you can't poop and you have to push it out, and nobody wants to give you an enema. So you need to be proactive on that. So the night of surgery, drink plenty of liquids. When you're starting to eat, don't jump into meat and potatoes. Instead, fruit and vegetables. You want lots of fiber in your diet that will help you with your bowels in that immediate postoperative period. And if you're a constipated person in the first place, clean out before surgery, take laxatives, and keep your bowels working. You would rather have the trots in 2 days than bricks in 4. But certainly keep an eye on it. If you normally have really good bowels, you don't even have to think about it, be thinking about it. If you haven't had a bowel movement in 2 days, you need to take a laxative and get things going and make sure that you don't get bound up. That's the best way to have a smooth operation after the operation. So when it comes to complications, nobody can tell you all the possible complications. There are a number of things that can go wrong. Your informed consent forms will give you a lot of answers there. But generally speaking, the more experienced your surgeon is, the less complications you're going to have because they've seen things before, and that experience helps them keep their patients safe. So at Meridian Surgery Center, you'll see a lot of experienced surgeons and providers at your bedside, guiding you through your operation to minimize your potential for infection.